Hi, this study discusses a novel methodology for measuring the medial proximal tibial angle, or MPTA, in total knee arthroplasty. I'd also like to thank the co-authors of the study. The MPTA describes the coronal alignment of the native tibia, with reference in relation to the tibial mechanical axis. It provides an understanding of the preoperative anatomy and is used as an input in numerous TKA alignment philosophies and classification systems. Clinically, the MPTA is most commonly measured on coronal radiographs, where it's defined as a medial angle between the proximal tibial joint line and the tibial mechanical axis. Although this approach has previously been proven to have a high reproducibility and repeatability, it's been shown to have relatively low agreement with 2D CT measurements. There have been prior attempts to define a 3D protocol for measuring the MPTA. For example, Metz and colleagues defined landmarks on the periphery of the tibial plateau. Although a high ICC of greater than 0.95 was observed, the mean MPTA of about 91 degrees is higher than found in published literature. And this may be due to the protocol being prone to osteophytes at the peripheries of the tibial plateau. The aim of this study was to investigate and evaluate various 3D CT MPTA measurement approaches and also compare these to the industry standard 2D measurement approach. In terms of methods, a retrospective study analysis was performed. EOS and CT scans were preoperatively obtained. The CT scans were segmented to create 3D reconstructed bone models, which were then landmarked to enable anatomical measurements. A total of 6 types of 3D MPTA measurements were taken. For all approaches, the MPTA was defined as the angle between the tibial mechanical axis and the proximal tibial joint line. However, the differentiating factor was how the proximal tibial joint line was defined and measured. The first approach defined this as the line joining the 2 3D landmarks, one at the center of each tibial well, medial and lateral. These landmarks were identified by engineers. The other 5 techniques relied on a regression line of best fit to form the proximal tibial joint line. This involved running a custom algorithm which identified 20 landmarks across a cross-section of the tibial plateau. The algorithm then calculated a line of best fit, which represented the proximal tibial joint line. This was assessed at 3 cross-sections: the anterior, which was 20% from the anterior edge of the proximal tibia, the central region, which was 50% from the anterior edge or posterior edge of the proximal tibia, and the posterior region, which was 20% from the posterior edge of the proximal tibia. We also used a combination of these cross-sections to create regressions, including the ACP, which considered points along the anterior, central, and posterior cross-sections, as well as the AC, which focused on just the anterior and central regions. A 2D MPTA analysis was also performed on a subset of 50 joints as a proxy for the industry standard. AP-EOS scans were used instead of AP radiographs, as these were captured as a part of the surgeon's standard of care. The mean MPTA using the industry standard 2D approach was 86.3 degrees, which was quite similar to what was observed for the 3D landmark approach. Comparing this to the remainder of the results, it can be observed that the regression methods, in yellow towards the center of the chart, result in a relatively more neutral MPTA measurement. This is expected because now we're considering the 3D topology of the proximal tibia as opposed to 2D landmarks or 3D landmarks. Further, the MPTA measurement becomes increasingly various as we move further posterior along the tibia. This further highlights the importance of considering the 3D topology of the proximal tibia. And as expected, the ACP and ACE combination of regions appear to average out their constituents, providing a large majority of measurements between 3 degrees various and neutral. So overall, the interpatient variability in the MPTA across all approaches was similar to what's previously been published in literature, with a standard deviation in the range of 2 to 3 degrees. The 2D and 3D landmark approaches result in a more various MPTA measurement compared to the regression techniques. And this may be due to the fact that these landmark techniques are more influenced by tibial well deformities. This has implications for alignment philosophies and classification systems, which ultimately rely on the MPTA as a source of defining the native tibial alignment. However, it's also important to consider the 3D topology of the proximal tibia. And for instance, the anterior surface was observed to be significantly more valgus relative to the posterior surface. So in conclusion, it's important to consider the 3D geometry or topology of the proximal tibia. Out of the techniques discussed, the ACP regression approach best considers this 3D topology as it averages out any potential deformities, or more so localized deformities. Our future work aims to investigate intrapatient variability, reproducibility, and reliability of the 3D geometric analysis. Thank you.